Assalamu alaikum, the long clinical consultation day. First scenario, Mrs. Sandra, 25 years old lady with a complaint of high body temperature. Vitals, blood pressure 110 over 80, temperature 38, and pulse rate 105. Take history, examine the patient, address the concerns. Ready?
Yes.
Here you go.
Hello, I'm Dr. Ala. I'm the doctor in charge today. Let me confirm you are Mrs. Sandra, 25 years old.
Yes, I am.
Mrs. Sandra, I'm here today to discuss with you about your health condition and to examine you. Is that okay with you?
Okay.
It came to my knowledge that you have been troubled with high body temperature. Is that right?
Yes. Right.
Can you tell me more about that?
Yes, so this actually started since 1 week to now. And sometimes it is relieved when I took paracetamol or like that, but return back.
Okay, I'm sorry for that, Mrs. Sandra. This is the first time to have this high body temperature?
Yes, since 1 week, yes.
Okay, and this high body temperature is with you all the time or it's coming on and off?
No, it is all the time, but when I take this paracetamol, it is relieved, but come back again.
Did you notice it's more in a specific time of the day, like more in the morning or more at the night?
No.
Did you record your body temperature?
Yes, in the first and second day, I recorded it. It was 38, 39 sometimes. But when I visited my GP, he gave me paracetamol and antibiotic. After that, become relieved by this paracetamol.
Okay, but it's still coming.
Yes.
Okay, do you have any excess sweat or night sweat?
Yes.
Since when it started?
Also, sweating started from this fever started, or this hypertension started, and there's also rigors. I mean,
Yeah. And this sweat, it's more in the night or no? It's like can come any time in the day.
when this but the temperature is high, it comes this sweating.
Okay. Do you have like severe sweating, like you have to change the bed covering at the night or not?
No, like that, not like that.
Okay. Did you notice any change in your body weight?
No, actually no. Just
Any
1 week.
lumps? Any lumps or bumps in your body?
I think there is a lump here in my neck. Also started since 1 week. Or my 6 days, like that.
Okay. Where is exactly in your neck?
In the side of my neck.
In the side. Can I see this lump or?
Yes, sure. I will share the picture, but continue your question.
Is it painful?
Yes, it is mildly painful.
Okay. And since this started, it's the same size or it's increasing or decreasing?
No, increase the size.
Okay. Did you notice any lump in another part of your body?
No.
Did you notice any unusual hot or cold intolerance?
No. I share the picture.
Okay. Do you have any sore throat?
Yes.
Since when?
Since also 1 week.
Okay. Do you have any cough?
Yes, mild dry cough.
Since 1 week also?
Yes.
Any shortness of breath?
No.
Any heart racing?
Yes, when this blood temperature high, it is heart racing. Yes.
Okay. Did you notice this heart racing is regular or irregular?
No regular.
Okay. Any disease spells?
Sorry?
Any disease spells?
No.
Any chest spell?
No.
Okay. Do you have any history of long-standing disease I should be aware?
No.
Are you taking any regular medications?
No. Just this antibiotic which given to me by in the I think in the second day I visited the GP and gave me antibiotic and paracetamol, but without benefit actually.
Okay. Do you have any headaches?
Yes, sometimes. When
Since when?
this since it's 1 week also.
This headache with you all the time or also coming on and off?
With the fever, with this high blood pressure, it's come.
Mhm. Did you notice this headache can increase by sneezing, coughing, or leaning forward?
No,
It's in a specific part of your head or all over your head?
over my head.
Okay, this headache you can grade the severity from 1 to 10, where 1 is the minimum and 10 is the maximum.
So maybe 5.
Okay, do you have any neck stiffness?
No,
Do you have any weakness in any part of your body?
no,
Do you have any change in your bowel motion?
no.
Do you have any difficulty of swallowing?
Yes, not difficulty, but I think it's painful swallowing.
Since when?
Also sensitively.
Okay. Did you feel any getting sick or do you have any feeling sick or getting sick?
No,
Did you notice any change in your water work?
I know.
Do you have any joint pain or back pain?
No, but it's more muscle pain. In all my muscles, I have
Mhm.
pain.
Okay. Muscle pain. Okay. Did you notice any skin rash or skin changes?
Yes,
Skin rash?
yes, maybe this is since 3 days or uh, after my visit to the GP, this is rash started to appear
What is exactly?
all over my body. I will share picture now.
Okay.
I will show in my legs, this rash in my legs.
Mrs. Sandra, can I ask you private questions if you don't mind?
Okay,
Do you have a partner?
yes,
Any history of casual unprotected relationships?
casual. What mean you casual with my partner?
No, casual unprotected relationships.
With my partner, it is unprotected. Yes, unprotected with my partner.
Okay. Do you have kids?
No, no,
Okay. Any history of tattooing or piercing?
uh, no,
Any history of blood transfusion?
no.
Okay. Any history of recent travel?
Uh, yes, since maybe 1 month, I traveled to Holland. Uh,
Okay. For how long you
uh,
stayed there?
maybe for 1 week.
1 week. With whom you traveled?
With my partner.
Okay. Okay. Uh, okay. Did any contact with sick people there, like people with lung problem?
No,
Okay. Do you drink from unbottled water or eat from street food?
no, no.
Okay. Can I ask you about your period? Is it regular?
Yes,
When was the last period?
maybe since 10 days.
10 days. Okay. I'm sorry, can I ask you, do you have kids?
No, was asked me.
Yeah, sorry. Do you smoke?
Yes.
Do you drink alcohol?
Yes.
Okay, I advise you to stop smoking because smoking is injurious for your health. And if you need help regarding this, I can refer you to smoking cessation clinic if you don't mind.
Okay. Thank you.
Can I ask you how much you drink alcohol?
In the weekends.
Do you binge drink?
No.
Okay, what do you do for living?
I am a teacher.
Any impact of your symptoms in your job and daily activities?
Yes, since I suffered from this hypertemperature, I didn't go to my work.
Yeah, I'm sorry, Ms. Sandra, for this. I hope we can help you regarding this by giving you the proper diagnosis and treatment for your condition. And if you need, we can write for you also medical note. Is that okay?
Okay.
Can I examine you?
Okay.
I start my examination by checking the patient observation chart for the vital. I can see that she has high body fever, 38, and also the pulse is 105. Okay, I need to check her hand for any clapping,
No clubbing.
tremors.
No.
Okay, I need to check also for osseous nodes, genuine lesions.
Nothing.
Okay, I need to check the pulse. Okay,
Okay.
regular or irregular.
Regular.
Okay, I need to check the blood pressure. Okay, I need to check the eye for pallor and jaundice.
Okay. There's yes, balloon. My balloon.
Okay, I need to check the mouth for any oral thrush or poor dentition.
Okay, I will share a photo for examination of.
I need to examine also the lymph node. I will do full lymph node examination.
Sorry, I will share the photo. Just I'm sorry for this. This
Full
is a
lymph
photo
node.
of mouth examination. The lymph node, just the cervical, just which I shared the photo for it.
Yeah.
Okay.
Okay. Also, I need to examine the chest. I will do chest auscultation for any bronchial breathing, any crackles.
Normal. No problem.
Okay, I need to do also auscultation of the heart for any murmur.
No murmurs.
Okay, and also abdominal examination for hepatosplenomegaly.
Here is blue megaly. Two fingers below the costal margin.
Okay, and also I need to ask for inguinal lymph node, and then I will examine the rash and also the leg for pitting edema.
Just the rash I shared and the lower limb edema, no lower limb.
Okay.
2 minutes left.
Okay, can I know what's your concern, Mrs. Sandra?
What I have, doctor?
I appreciate your concern, Mrs. Sandra. Actually, from our discussion today and my examination to you, there are multiple causes for your condition. One of the most possible causes that maybe you have a condition called infectious mononucleosis. This is this type of infection caused by a virus which can cause this sore throat and the cough, and also the rash that you had, and also this lump in your neck. Okay. Do you have any other concern?
How I catch this infection, doctor? And is it treatable?
I appreciate your concern, Mrs. Sandra. Yes, there is a treatment for this condition. How you catch this the infection maybe it's related to problem in your defense system. Okay, so we need to run some blood test for you and to confirm first our diagnosis, and also we'll do some imaging. Then we will talk to you about the result of this test and also our management plan. Do you have any other concerns or questions?
And this rash, doctor, is it measles? Because I know measles. Before in my childhood, I got measles. Is it measles?
Actually, Mrs. Sandra, I don't think this is measles. But can I ask you, did you receive vaccinations for measles?
Yes.
Okay, I don't think this is measles. But as I told you, we'll run some blood test and imaging, then we'll come back to you and discuss your condition, okay?
Yeah, time is up. Perfect, Dr. Ala. We examine the questions.
Okay. Can you present your sort of finding?
So today I saw Mrs. Sandra. She's 25 years old. She presented with fever over the last 1 week associated with excess sweat and also lump in her neck, and she had sore throat and cough and headache, and also she had painful swallowing, and also she had skin rash with history of recent travel. And I assessed HIV risk, but she told me only she had unprotected relationships only with her partner. On examination, I could appreciate that she had pallor, and also she had cervical lymphadenopathy and splenomegaly with erythematous rash, and also she had follicular tonsillitis.
Okay. Any other positive finding?
I think no, these are the positive findings.
Okay, so what's your differential diagnosis?
So my first differential in view of these findings can be due to infectious mononucleosis. Also, I need to exclude HIV, and also although there is no history of weight loss or excess weight, I need also to exclude TB infection with the recent travel history. My least differential can be lymphoma. So only she has only single lymph node.
Okay. Okay, so how can you investigate this patient?
I need to do for her basic blood test. I need to do full blood count and also ESR and CRP. I need to do urea electrolyte. I need to do for her liver function test. I need to do for her imaging abdominal ultrasound, and also I need to do
what you expect to see in CB complete blood count in this patient?
Complete blood count. I need to check for lymphocytosis and also if there is neutropenia.
Neutropenia. Okay. Anything else?
Okay.
Okay.
I need to do for her Epstein-Barr virus serology, and also maybe PCR for Epstein-Barr virus. And also I need to do for her HIV test, and we can take also lymph node biopsy.
Okay. So how you will treat this patient?
So patient education counseling about her condition, and the treatment will depend on the result of the investigations with the involvement of multidisciplinary team, especially the infectious disease team, and also maybe the pulmonology and specialized nurses. The treatment, so I don't remember the treatment for Epstein-Barr virus. Don't remember
Sorry?
that. I don't remember the treatment for Epstein-Barr virus. I don't know if it's supportive treatment or there is specific antiviral.
Okay. So I want to ask you in the treatment, is there any need for giving antibiotics in this case?
I don't think she needs antibiotic, but we need to confirm first the diagnosis, and then we will pursue the treatment
Okay.
according to the blood tests and the result of the investigation.
Okay. So, do you know any complications for infectious mononucleosis?
Complications, I know the splenomegaly and also the lymphadenopathy and the skin rash.
No, this is the symptoms. The symptoms.
Yeah, the associations.
Manifestation.
No, I
Okay.
don't know the complication.
Well done. Well done, Dr. Ala. Very good. I will just comment about in history. You've covered
Dr.
actually.
Hani, just one question. Will you admit this patient or no, Dr. Ala?
No, I don't think she needs admission. Only investigations outpatient.
Okay, as every case advice, whenever you have the decision to admit or no, you can't postpone that. Don't say just no. Okay, even if it's no, the answer is no or no admission, but say I will admit to the emergency to run some blood test, and after confirming no complications, a patient might follow up with the OPT. But don't say no admission. Okay, just be safe. Be safe, doctor. You will not say admit, but I will not also say discharge. Just to admit temporary till the result will be released. Okay, be safe for this answer. Okay, Dr. Han, you can comment now.
Okay. About the analysis of the complaint, you do it well. Okay. About what you missed, I think just you missed the family history only in your history. But you covered the travel history is very important. Sexual history is very important. Okay. In sexual history, you asked about a casual relationship. She said no, and unprotected casual relationship. Firstly, you will ask about is there is any casual relationship or not. After that, if there is casual relationship, you need to ask about who's protected or unprotected. Okay. About there is a missed question about the partner, because the partner have also the same condition. Since after they returned from the travel, the partner have fever also and improved now, because it is a transmission of infectious mononucleosis mainly during kissing. Okay. So this is just the important question in the history. About the examination, you covered the examination very good. There's maculopapular rash and pallor, cervical lymphadenopathy. You need to examine the lymph node. It is firm or what mildly tender, discrete, like that. You need to palpate the lymph node. So it is firm, mildly tender, and discrete. There's also congested pharynx and exudative tonsillitis. You may find also palatal petechiae, splenomegaly, and maybe plus or minus mild hepatomegaly. Okay, this is the most common finding in like these cases. About the concerns, how to answer the concern of the patient. From our discussion and my examination, mostly you have an infection called infectious mononucleosis. It is caused by a common virus called Epstein-Barr virus, and it spreads mainly through saliva. as example, during sharing drinks or coming in close contact during the intimate relationship. And this will solve her concern about how she captured this infection. So if it is usual when we talk about an infection, we need to talk about the route of transmission. And this causing the symptoms you have: high body temperature, tiredness, and swollen glands in the neck, and sore throat. Why I have a rash, if they concern, why I have a rash, and is it a measles? No, it is not measles, but some antibiotics cause a rash in this illness because it is viral, not bacterial. Mostly the antibiotic given by the GP, which trigger this rash. And mostly this antibiotic is amoxicillin. Sorry. So you will change this antibiotic. No, antibiotics don't help because this is a virus, and also there is no specific antiviral treatment needed, and the management plan will be rest, and we will give you fluids through your blood channels, and medicine for high body temperature, and the infection will subside spontaneously and recover. You will recover completely. Is it serious? Mostly no, and you will recover completely. But some serious complication rarely may happen. So we need to avoid a heavy exercise and contact sports because your spleen is enlarged. And if you feel any severe abdominal tummy pain, you need to come urgently to the emergency room. Also, if you developed any difficulty breathing or swallowing or yellowing of your eyes or skin, you need to come to the ER. So you need to give these advices, especially the spleen, because she is prone to rupture spleen. About the differential diagnosis: infectious pneumoclosis, the first. The second will be acute HIV infection, seroconversion. Okay. The third will be cytomegalovirus infection, TB. Okay, we can put also streptococcal pharyngitis with drug reaction. We can also put hematological malignancies like lymphoma or like leukemia, lymphoma mainly. Okay. How can you investigate this patient? The basic, as you said, about the finding in sorry, 1 second. Sorry. About the finding in the CBC, you will find leukocytosis with absolute lymphocytosis with atypical lymphocytes. So leukocytosis with absolute lymphocytosis with atypical lymphocytes. Okay, we call it Downey cells. It will be more than 10% on the peripheral smear. And you will find mild thrombocytopenia and mild hemolytic anemia. Okay, mild anemia. This is a CBC finding. Okay, after that, about the investigations, peripheral blood smear. Okay, you will also find in the peripheral blood smear large atypical lymphocytes. Okay, and in monospot test, heterophile antibody test. Monospot test is screening test of choice for infectious mononucleosis. Heterophile antibody test or monospot test. Maybe negative in early, okay, in early stages. After that, we will do Epstein-Barr virus specific serology, and this is the gold standard, IgM and IgG. It will be positive. So, specific investigation to confirm will be peripheral blood smear. We will find large atypical lymphocytes, heterophil antibody test, and Epstein-Barr virus specific serology. After that, we will do investigation to exclude other infections like cytomegalovirus IgM, HIV test, toxoplasma IgM, hepatitis B serology. Okay, and ultrasound, abdominal ultrasound as imaging, and chest X-ray, and also abdominal ultrasound because there is splenomegaly. Okay, how can treat? The treatment will be supportive. Supportive treatment or non-pharmacological treatment. Okay. Supportive treatment, rest and education and counseling. Okay. Rest also and hydration, oral or intravenous fluids. If the patient is unable to maintain oral intake. Antibiotics and analgesics like paracetamol, but we avoid aspirin because there is a risk of Ray's syndrome, and avoid also non-steroidal because if the liver is affected. Avoiding alcohol and smoking, a gradual return to work and sports, because we say to avoid to contact sports because fear of rupture. This supportive treatment or general treatment is specific treatment. Antibiotics, we need to avoid antibiotics, especially amoxicillin or ampicillin, because causing rash and don't help. Only give antibiotics if there is a proven secondary bacterial infection. Okay. This is about the antibiotics. Antiviral therapy, acyclovir. This reduces the viral shedding, but not recommended routinely. Not routinely recommended. Okay, because it is self-resolving and mostly infectious mechanism. After that, the corticosteroids, also not routine as the antiviral, only in impending upper airway obstruction. If there is impending upper airway obstruction, we can give corticosteroids. Or if there is severe tonsillar hypertrophy causing dysphagia or breathing difficulty. Okay. Or if there is severe hemolytic anemia or thrombocytopenia or any CNS complication, in this situation we can give corticosteroids, but not routine to give corticosteroids or antiviral. After that, we will give treatment of complications. So about the treatment, supportive or general treatment, antibiotics and antivirals treatment, and after that, or specific treatment. After that, treatment of complications if happen. The complications here will splenic rupture, is the first one, upper airway obstruction, hemolytic anemia, thrombocytopenia, hepatitis, myocarditis, chronic fatigue. This is the most common complications of infectious mononucleosis. So if there is a splenic rupture, it is emergency surgical issue or care. If there is any hepatitis, you need supportive care and avoid hepatotoxic drugs. Or secondary bacterial infections, we will give antibiotics. This is a treatment of complications. I finished my comment.
Really perfect and amazing. Fantastic performance from Dr. Ala, and mashallah, the topic well prepared from Dr. Hani. Really, the topic is covered from every point. If I will comment just to be more complementary, how to fill the defects only for Dr. Ala. Otherwise, knowledge-wise, information Dr. Hani already covered. The case as organized history and examination by Dr. Ala was perfect. Really, you deserve the full mark. I will minus you only for my question. Will you admit or no? And the answer is not never to be no. Okay? Never to answer any examiner for admission no. Even for the simple complication or simple complaint, try to be safe, doctor. I will admit to the emergency to run some blood tests to confirm my diagnosis. You don't know what the diagnosis. This is the first point. Second point, there is possibility to have a complication. As Dr. Hani mentioned, airway compromise because of the swelling of the tonsil, splenomegaly, huge splenomegaly. Even one of the complication happened during the examination. You catch it, Dr. Ala, the pallor. Patient is pallor or pale, is having pallor. So there is possibility of anemia. At least show the examiner, I will wait for the result. Maybe there is anemia, but patient might need transfusion. Okay? Although you rolled out the dizziness because of anemia, which is very perfect question when you ask about dizzy spell. Why Dr. Ala asked about dizzy spell in this scenario? Because dizziness is one of the constitutional symptoms analysis. Whenever you have any of positive constitutional symptom as a complaint, try to analyze the others. Why? Because it affect the the all body autoregulation. What I mean, fever sometimes it can cause autonomic disability, tachycardia, hypotension. There is an ongoing infection. It might be complicated with sepsis, so you don't know what's ongoing. Sometimes it will be associated with serious infection, HIV, or malignancy, or connective tissue disease, or autoimmune disease. So you have to analyze the other constitutional symptoms, starting from fever, lumps or bumps, and a night sweat. Okay, night body temperature, which is our complaint today, dizziness, and jaundice. Add to your analysis, Dr. Rala, the jaundice. You have any change of your eyes color. Why? Because, as I said, the constitutional symptom or system will be reflected by other analysis of or other complication of the constitutional symptom or system. TB, one of the possibility. By the way, you can add TB as differential here, TB lymphadenitis. However, patient doesn't have night sweat and loss of weight. Yeah, the other complaint or other system affected or the other constitutional as analysis will be loss of weight and the loss of appetite. It's very important to ask these questions whenever you have any of them as positive, as our case today. So loss of weight and loss of appetite, Dr. Ala already rolled out. Dizziness for anemia rolled out, or autonomic disability. And the case about here, it was for just infectious mononucleosis. So the patient has only fever and some sweat and kills or chills. It was also because of the high grade fever. You can also analyze for malaria, or you can add it to the differential because of the travel history. Okay, so Dr. Ala, you can mention it, but however, you have to ask about any skin bite, okay, any bite or mosquito bites, especially in the countries with malaria, endemic with malaria. For example, if the patient traveled to Africa, try to put one of your questions and differential malaria. And the fever question will be very target question. Do you have fever comes and goes in regular manner? Every day, every 2 days, cyclical fever, as we know. Especially if you have travel history to those countries. Okay, either Asia, Thailand, and the other side of country, which is Africa. Okay, this regarding travel history. I want just to add this question to Dr. Ala analysis. So what he analyzed for travel, he asked about food. Did you eat from outside? And he asked with whom you traveled. Ask about him. With whom you travel and how is he? Makes sense to ask about his partner or her partner because might be he is the one also infected. Either he get the infection and he transmit to her, or the opposite. So for the welfare, you have to ask about How is your partner, or who was with you? Yes, my partner. How is he? Did he had the same condition? Yes. So you might have also explanation of the finding, or to admit the husband. Maybe he's the one carrier and he had the infection first. Okay, or for some other condition like diarrhea, gastroenteritis, all group will be infected, so you will have the clue. Do you have travel? Yes. With whom? With my friends. Any of them has the same condition? Yes, they have. All of them, they have the diarrhea. Now you have some clue about the possibility of diarrhea. Is it traveler diarrhea? Yes. One of the top definition will be traveler diarrhea. Okay. This is as travel history. So whenever you have travel, ask about to where, which country. If you have malaria countries, you have to ask about vaccination. Did you get any vaccination before and after and during? Yes, yes or no. Then the food. If you have gastroenteritis, how was your food? Did you eat from the restaurant or from outside? And the third or the fourth question will be for the bite. Any bite from any fly or mosquito. Sometimes the hiking, it came before, by the way, the hiking. Patient came with history of hiking, and you know the case was. Do you know this case, Dr. Ala?
Yes, rickettsia
No, not
or
rickettsia.
Lyme.
Lyme
Lyme
disease.
disease.
Lyme
Yeah,
Lyme
disease.
disease.
Lyme disease came before in the basis, either neurological or the same lymphadenopathy. So be careful if you have a country with hiking or mountains and forest. So ask about any hiking or any going outside. And if the patient went outside, he should have a net, should be protected from this bite. Okay. As I said, it's perfect as organized one from Dr. Ala, and Dr. Hani also cover the topic well. For the admission, again, if you don't have any serious complication right now, tell the examiner I might admit him to the emergency until the result will be released. Clear answer and very safe answer. He will not say, no, you are not safe. And he will not say, no, the patient doesn't need admission. No, to be safe and to say, I will not shift or I will not discharge this patient, better than saying, I will discharge this patient. So I will keep him temporary, even without admission to the ward, till the result will be released and that the group of doctors or the multidisciplinary team finalized the investigation and the decision of discharge, because you are still not the doctor to discharge him. You are not the primary. Okay. The other question regarding the medication, if I don't know the pharmacological option, no need to show the examiner that I don't know. Okay, because it is your, you will be in this case today, you will be the one volunteer to say, oh, I forget the medication. Even if I don't know, the best and safest answer for any infection, I will start or I will refer to the infectious disease team to give the medication or the antibiotic or the antiviral according to the local policy. He will not ask you what is the medication. If you give this answer, it's very safe and perfect and professional answer. You can get the full mark if you say this. Okay, doctor, but don't say I forget. Here it's not no medication, no pharmacological option, just as Dr. Hani said, some painkillers, analgesic, antibiotic, no, it's just hydration, supportive management. Most of the viral in this way. To be aware about viral infection in cases, most of the viral, even dengue, dengue fever also supportive. Most of the viral, especially those with the lymphadenopathy, they don't have specific measurement, except I think the cytomegalo for giant cyclovir. Otherwise, most of them, and hepatitis, of course, but other most virus will be given as or maybe be treated as supportive treatment, and some analgesia, hydration. Okay, and here in this case today, avoid antibiotic because it will increase or it will lead to the eruption of the skin rash. Okay, you have any question, Dr. Ala?
No, thank you, Dr. Bassem.
Okay, the cuff, I forget the last point. If you have a cuff, you have to know what the nature of the cuff. Yeah, maybe today it's not that significant, but maybe in another case will be significant, like TB. You have cuff, yes, analysis of the cuff. What the nature of the cuff? Is it dry or productive? Yes, I have some phlegm. What the color of the phlegm? Does it contain blood? You ignore it at all. He
No, he
told
told
me,
me
ah,
dry cough, so he
okay,
told
sorry.
dry cough.
He said, okay, if he said I didn't hear it. But
Mm.
if he didn't, you have to analyze it. Okay? Thank you, Dr. Ala and Dr. Hani. I think we are done with this case as really it was perfect, as I said, nothing to be added. Now, the second scenario. Dr. Hani, Dr. Ala, did you post the scenario?
Yes, Dr. Bassem, I bought it.
Where is it? Ah, yes, okay. You are the doctor in the admission assessment unit. Patient name Mr. Sami Ibrahim, 50 years old, problem the fatigue with hemoglobin 8.5. Observation chart 110, blood pressure over 70, pulse 80, temperature 37, saturation 98. Now we can give Dr. Hani 2 minutes and open the discussion. Anyone want to add any comment? You're welcome. Feel free to comment.
Dr. Bassem,
Yes, sure.
Doctor, regarding this case, we need to advise the patient about to avoid sharing stuffs with and sharing with the others, like as this can be transmitted by saliva.
Yes, perfect. Yes, you can add. And Dr. Hani already mentioned it. And thank you, Dr. Raghat,
Okay.
for this question.
Okay.
One of the indication to admit this patient. But before that, I will ask you, Dr. Raghat, because you asked this question. Do you know about the Epstein-Barr virus, infectious mononucleosis? Is it notifiable disease? Do you know?
I don't know actually. No.
Okay, and mostly, is it notifiable or no? What do you
I
think?
I think no.
Yeah, it's not a notifiable disease. Perfect. This is the first point. So it's not notifiable, but you have a suspicious of HIV in this scenario, right? So I cannot discharge this patient. This is one of the second indication of admission, Dr. Ala. So you have two possibility or two indication to admit this patient temporary. Maybe even you will admit to the ward because some screening will take time. Okay, let's talk about this case as admission. One of the first decision is the screening itself. I have to screen for the infectious mononucleosis, Epstein-Barr virus, IgM, IgG antibody. It will take time. So if the patient has any complication like splenomegaly or airway compromise, I will admit the patient and I will wait for the result. If no complication, he can go or she can go home, then I will update her about the result. This is the first indication. The second indication, I suspected HIV, right? So I have to run the test for HIV. Not only that, I have to ask for the wife or for the husband to screen for her or for him the HIV. The third one, as a complication, the pallor or the dizziness or the complication as general complication, which is hemolytic anemia. Okay, so there is local complication we said about the airway, but there is also general complication, which is anemia. And the third is indication to admit the HIV screening if I suspected the HIV. However, the patient doesn't have the risk factor for HIV or any risk habit, but you don't know. Maybe the husband has a HIV and she got it from him, right? The take home message, if you will say better to admit the patient till will be discharged or the decision will be taken by the multidisciplinary team, or the patient will be admitted for the complications possibility. But never ever say, I will discharge the patient or I will refer the patient to the OPD, yes, I can do, but after the result will be released. So be safe by this answer for any condition and any presentation. Okay. Thank you, Dr. Ragad, for your question, and we can start the second scenario. If any question before starting the second scenario.
السلام عليكم دكتور باسم عيد مبارك.
عليكم السلام. أهلا دكتور.
Yes,
Welcome, Dr. Mohammed. How are you?
thank you, Dr.
Alhamdulillah.
Basim. Really very good case from Dr. Hani and well done, Dr. Ala. Very organized, really very organized.
Yes.
But I have question. Does Dr. Ala ask about when there is lumps in his neck? Did he ask about it is painful or painless?
I think
Yes,
even
yes,
No.
yeah. Yes, I asked
asked.
it.
And also move with the swallowing or not? Because it would differentiate between it is malignancy or inflammatory.
Perfect. He asked, Dr. Hani commented in this on examination. He didn't ask about the consistency and the movement in the examination.
And it's
Yes.
soft or firm.
Perfect, yes. And tenderness, yes. You're right.
Thank you, Dr. Basim.
And other groups of lymph node, you have to offer all the
Yes.
lymph node examination, Dr. Ala. Dr. Ala, yes.
And also
Started
during
by the cervical, yes.
Yes, Dr. Basim. Yes. During examination, during the discussion with the examiner, he should specify the site of the lymph node, which is posterior cervical or anterior cervical. It is firm or soft. It is painful or painless. It is moved with swallowing or not. Very important.
Perfect.
Lymph
Yes,
node.
perfect. Thank you, Dr. Musa. Yes, you're right.
Thanks, Dr. Basim.
One more point you remind me about, which is the surgical history. Whenever you have fever, believe me, there is a hidden past history you have to ask. Maybe this patient had a procedure and he just ignored it by this fever. Okay, so remember to ask about any surgery before or prior to this fever. Maybe he had thrombophlebitis, he had pacemaker, not in this patient, but maybe the other case. Okay.
Yes, come before discitis.
Exactly.
Back pain with
discitis.
Yes.
Perfect. Yes. So be sure that you cover the medical history, including Dr. Ala covered the medical long-standing disease and the medication, but he didn't ask about surgery, which is very important. He put in his differential HI the infective endocarditis, which is perfect. But you have to know why this patient have infection, from where the source of infection. Here it was clear the airway, or sorry, from the nose or from the tonsil or from the upper airway. But or so maybe in another condition you will not know the source of infection. So you have to know the source of infection. As I said, usually you have infection in a system, you have to analyze which system the infection is.
Yes.
CNS, neck stiffness, already covered, Dr. Ala. The airway or the gastroenteritis, he asked already about the gastro, the cough for chest, blood for infective endocarditis, urinary or genitourinary for UTI, and the musculoskeletal connective tissue joint. He covered everything, but the past surgical give you a clue if you have a discitis, a case of discitis, or it might be also a clue for the infective endocarditis. So the source will be the surgery or the entrance from the blood itself. Okay. Okay. I think we are done with the first case. Now we can start with Dr. Hani.
Yes.
Here you go.
Okay. Hello there.
Hello?
I'm Dr. Hafiz, a doctor in the clinic today. Can I confirm that I'm talking to Mr. Sami Ibrahim?
Yes, doctor, I am.
Nice to meet you, Mr. Sami. Mr. Sami, I'm here today to discuss your health condition, so I will ask you some questions. After that, I will examine you and address your concerns. Is it okay with you?
Yes, doctor, it's okay.
Okay. Can you tell me what brought you in hospital today?
Actually, doctor, over the last couple of days, I'm feeling tired. When I'm doing effort, I cannot manage. Then I went to my GP and he did for me blood test and he told me I have low blood count. Then he referred me to you.
I highly appreciate. I'm sorry for all your suffering and I appreciate concern. and I will try to do my best to help you today. So, can you tell me just this tiredness exactly started since 2 days, you say, or what?
Since a couple of days, maybe 5 or 6 days.
Okay. Okay. And this is the first time you are suffering from this tiredness?
Yes, doctor.
Okay. And from this start, it is increase or decrease or the same?
Yes, doctor, I think it's increasing.
Okay. And it is go on and off or all the time?
It's especially when I'm doing effort.
Okay. And no different in the daytimes from the morning or at the
No,
end of the
doctor.
day?
No.
Other than doing effort, do you notice anything increases tiredness?
No, doctor, only when I'm doing effort.
Do you notice anything relieve this tiredness as rest
It's,
or
be- it's better with rest, yeah.
okay. Okay. So any high body temperature?
No, doctor.
Any lumps or bumps on your body?
No.
Any change in your weight?
Yes, doctor, I'm putting on weight.
So how many kilos and for how
I
long?
think I put 10 kilograms over the last year.
So you put in there is increase in your weight 2 kilogram in 1 year.
10 kilogram.
10 kilogram.
Yes.
Sorry. In the last year. Okay, and that's intentional or unintentional?
No.
Unintentional.
Yeah.
And what about your appetite?
It's okay.
A normal appetite.
Yeah.
And what about your physical activity?
It's my usual, doctor. No change.
Okay. So any lump in your neck?
No,
Not your
doctor.
neck. Any valor became pale or anyone inform you that became pale?
Actually, I didn't notice, doctor, but my GP did the blood count and they told me I have low blood count.
Okay, but you didn't notice any valor.
No, I didn't notice that.
Okay, so any headache?
Yes, doctor.
Since when?
I think now more than 6 months if I have headache. Yeah.
And this headache increase with time?
No, the same.
And go and on and off or just all the time?
Yes, it's coming, but mainly in the morning. I feel more headache in the morning.
Increase in the morning.
Yeah.
Okay. And do you notice anything other than this time of the day in the morning? Any like are you sneezing, any coughing, leaning forward, or lying down?
Yeah, when I'm lying
Increases.
down, yeah. Yeah, when I'm lying down, I feel more headache, yeah.
Okay. Okay. So where's the site of the city?
It's all over my head.
Okay. And it is all the time, or go under.
It's more in the morning.
Anything relieve it?
Actually, doctor, I didn't try anything for it, yeah.
Okay. So do you have any loss of consciousness?
No.
Any feeling dizzy?
No.
Okay. Any shaking of your body?
No.
Any shaking of your hands?
No.
Any weakness in your body or in your limbs?
No.
Any change in sensation in your body, like numbness, pins and needles in your body or your limbs?
Yeah, I have some pins and needles in my hand,
Which hand?
in the right hand.
Since when?
I think since 6 months or so.
And does it increase with time?
No, the same.
Any trauma?
No.
It is relieved by shaking your hands.
Yes.
Increase at night.
Yes.
Okay. So, do you have any abnormality in controlling your water work and bowel work? Sorry for asking
No.
this question.
No, doctor.
Okay. Do you have any problem in your vision?
Yes, doctor. I have some blurred vision.
Since when?
I think since 6 months also.
Any double vision?
No.
Any bumping in your object?
No.
Any problem in peripheral vision?
Mm, I don't understand.
Any problem in the seeing the side objects like?
No, I didn't notice that, doctor.
Okay. Okay. So, any chest pain?
No.
Any shortness of breath?
No.
Okay. Any limb swelling, leg swelling?
No.
Any cough?
No.
Any coughing of blood?
No.
Okay. Any tummy pain?
Yes, doctor. I have tummy pain
Since when?
since 1 week.
Where's the side?
It's an upper tummy.
Over your tummy? Okay.
No,
And
my upper tummy.
upper tummy? Okay.
Mm.
And it's the first time you are suffering this?
Yes, yeah.
Okay. And please, with time
No, the same.
associated with food?
No, I didn't notice.
Any getting sick or being sick?
No.
Any throwing up blood or like that?
No.
Any passing blood from the back passage?
No.
Any change your bowel habit?
Yeah, I have loose motions.
Since when?
Since I think also like over the last 5 days.
Okay. And it's the first time or recurrent or
No, this is the first time, yes.
any blood in this loose motion?
No.
Okay. So it is watery?
Yes.
Okay. It is easy to flush or difficult to flush?
Yes.
What, easy or difficult?
Sorry?
Difficult to flush?
No, it's easy.
Okay. Any slime inside?
No.
Okay. Okay. So any urinary discoloration for skin or eyeballs?
No.
Any change in your water work?
Yes, doctor, I'm passing more water work
Okay. Since when?
since 1 year.
1 year.
Yeah.
Any diagnosis for diabetes or?
Yes, doctor, I have diabetes.
Okay. And it is controlled or not controlled?
No, not controlled.
What is the last HbA1c?
8.5.
8.5. Okay.
Mm.
Any problem in the water work other than frequency, the increase of frequency?
No.
Okay. Any joint pain?
No.
Any skin rash?
No.
Okay. Any bleeding from any body orifice?
No.
Okay. Okay. Any past medical history other than diabetes?
No, doctor, only diabetes.
Okay. Any medication? What's the medication list?
I'm taking glycoside and metformin.
Glycoside and metformin. And inhalable medication?
No, doctor.
Okay. Sorry for asking this question. Any anesthetic medication?
No, doctor.
Okay. Any family history of the same condition?
No.
Okay. Any disease running in your family?
Actually, I don't know, doctor.
Any recent travel history?
No.
Okay. Okay. Any are you married?
Yes.
Okay. Do you have any problem in your relationship, intimate relationship?
Yes, doctor.
What's the problem?
I think it's the problem in all, and also I'm not interested in it anymore.
Okay. You mean desire?
Yeah.
Okay. Okay. What you are doing for a living?
I'm accountant.
Do you drink alcohol?
No.
Do you smoke?
No.
Do you drive?
Yes.
Okay. I want to advise you to stop driving till now until we confirm your diagnosis, because you have a problem in your vision. How does it sense to you?
Yes, it's okay.
Okay. So I can examine you?
Yes, doctor.
Okay.
I
We'll
put the
start by
patient photo
general.
in the chat if you can see it.
Sorry?
I put the patient photo in the chat.
Okay, I see.
2 minutes left.
Okay. I see the picture now. Okay. So I see there's okay. I will examine the hands.
Okay. 4.
Okay. For any large hands and.
Yeah, he has large broad hands.
Okay. I will check the pulse and I will check the jugular venous pulse.
It's normal.
The cardiovascular examination.
Sorry, I didn't hear what?
Cardiovascular examination.
Yes. Okay, normal.
And the abdominal examination.
Okay, nothing.
Okay, any lower limb edema?
Sorry, he has only epigastric tenderness. Huh?
Any organomegaly?
No.
Okay. So, what's your concern?
I'm concerned about the cause of this tiredness, doctor, and low blood count. And is this something serious?
I appreciate your concern, Mr. Sani. And from our discussion and examination, I think you are suffering from a medical condition called acromegaly. This is because there is increased secretion of the master gland in your brain, and maybe this is causing you symptoms as you have. Okay. I continue.
Okay, is that something serious, doctor?
Serious or not treated, we need to evaluate your condition and do some investigation. After confirming the diagnosis, we'll give you the proper management plan. So you need the treatment. If there is a treatment, it will not be serious.
Okay, doctor.
Okay. Any other concern, Dr. Ala, you want to add?
I need to be admitted, doctor?
Yes. We will admit you to do the private investigations. After that, we will evaluate your conditions.
Okay, doctor.
Okay. Time is up already. Now you can start the exam question, Dr.
So can you present your case, positive findings, and the differential?
Okay. My
The voice being interrupted, this is for me only, or
Yeah. I think from Dr. Hani side, you have
Dr.
some
Hani.
breakdown. Check the connection, Dr. Hani.
Okay. Double now? Double now?
Okay, yes, continue.
Yes.
Okay. She's suffering from fatigue since 5 days and increase with effort, exertion, and there is weight gain and headache since 6 months, and bends and deans in the right hand since 6 months also, blurring of vision, and there is abdominal pain and diarrhea, and there is polyuria since 1 year. Okay, from the examination, I can find the features of acromegaly. There is large face with protruded large hands and feet, and also prognosis and broad elongated face. Okay. The abdominal examination, there is gastric tenderness. Just this my finding. Okay.
Okay, what's the differential?
My first differential is for this fatigue, and it is be associated to anemia, associated with his condition acromegaly.
What do you think the cause of anemia?
The cause of anemia in patient with acromegaly may be secondary to the chronic disease itself, or maybe from colonic cancer, because there is a high risk of colonic cancer in these cases, and the patient also have abdominal pain and diarrhea.
Okay. Any other differential for anemia in this patient?
In this patient also, I will put iron deficiency anemia, caused by maybe intake, or there is no, actually against that, there is no bleeding or any problem in his diet or his appetite.
What's your expectation of polyuria in this patient?
It is mostly diabetes secondary to acromegaly.
Any other explanation?
Yes, maybe increased antidiuretic hormone, SIADA.
SIADA will cause polyuria?
No, sorry. Diabetes insipidus.
Okay. What you will do for the patient? What's your investigation?
Actually, I will first do the basic investigations. Okay. By doing complete blood count. Okay. And liver function test, renal function test, electrolytes, and inflammatory markers. After that, I will do MRI pituitary to confirm my diagnosis. Okay. Also, I will search for any association with this acromegaly to this maybe is associated to other syndromes like MIN 1-2, multiple endocrine neoplasia. So I will search for any serum calcium.
This patient has multiple endocrine neoplasia?
There's some manifestations like abdominal pain and diarrhea, and maybe caused by viboma or gastrinoma. And this polyuria also can caused by hypercalcemia. This hyperplasia of
Yes.
parathyroid hyperplasia.
So what you will do for hypercalcemia?
I will do serum calcium and parathyroid hormone, serum parathyroid hormone. Okay. And also I will do hormonal profiles, prolactin and other hormones, cortisol, CTH, and
What's a
I
specific
will do
test for acromegaly?
For acromegaly, insulin growth factor.
Yes.
Okay. Yes.
Any other test?
And oral glucose tolerance test.
Yes. What's the treatment for acromegaly?
Treatment of acromegaly will be a transsphenoidal resection. Okay. This is a definite treatment. Okay. We can give octreotide. Okay. And اللي هو octreotide is what yes, somatostatin analog. Okay. Octreotide. Okay. And cabergoline also. Cabergoline, dopamine agonist, I mean. Okay.
Okay. Thank you, Dr. Hani.
Okay.
Okay, thank you, Dr. Hani. Dr. Ala, comment, please.
Dr. Hani, my comment only for the approach, okay? Because if you you little modify the approach, I think you will get the case rapidly, and also you will also adjust your history based on the case, and you will not lose that much time, because you lost a lot of time searching about systems there and there and there because you didn't get the case, okay? So the approach from the first, if it's like more organized, you can get the case rapidly. So you will ask questions more related to the case, because this is one of the wealthy case to have a lot of questions and a lot of examination you should cover. So you have to cover them rapidly. So the first thing.
Actually,
Yes.
I didn't see the picture, and you lately you said I shared the picture.
Yes, but sometimes they are putting the patient behind the curtain. You cannot see, and you are talking. You are talking to
okay,
the surrogate.
But also when I say asked about if from the first after analyzing the complaint, I asked about the past history. You give me negative past history. So how I can reach the diagnosis? I didn't see the
He
patient.
doesn't have past history, only diabetes, only past history.
Okay.
He doesn't have past history.
I mean, if I know he have diabetes from the first, I also it will not benefit me.
I'm not talking about the past history. I'm talking about the approach. Okay. So the first thing that you have here tiredness, okay, and you have also anemia, okay. So as you did, your approach to the tiredness was wonderful. Okay, you checked everything about the tiredness, the variation, and everything in relation to effort and increasing or decreasing. Okay, then the constitutional symptoms, as you checked already, and you found one thing positive, which is the weight change, which is increase in weight. This increase in weight needs its own analysis. Okay, how much over how long? Where is exactly you put the weight? It's all over your body, on a specific part of your body. And also one of the important questions, any change in facial appearance and any frequent change in the hand and the ring or shoe size. Okay, this will give you a clue that the patient is acromegalic. Okay, if he give you the answer that there is change in the facial appearance and change in the ring and shoe size, so you will get the case. You will get that this is you are dealing with acromegaly patient. Okay, so this is the first thing regarding the weighted change. So you have now acromegaly patient, okay, or you have patient with increased weight. If any patient with increased weight, you have to ask specific questions, okay? He give you that he has hand pain already because of the carpal tunnel syndrome, and this should be also examined during the examination. You should ask about snoring at night for the obstructive sleep apnea, and also you should ask about joint pain for the osteoarthritis. These are the complication of weight gain at the general, okay? Then the acromegaly itself, it has also its specific questions, and you should exclude multiple endocrine neoplasia. So you found acromegaly, it has its own questions, and also you should exclude multiple endocrine neoplasia. You have another complaint here, which is anemia. You should search what is the cause of anemia, why he has anemia. So there are also specific questions for anemia, okay? You should ask any bleeding from any body orifice, and you asked it already. Any black stool. Should ask by name about black stool, because this is I think also Dr. Basil know it. This is coming in the exams. If you didn't ask about black stool, they will not tell you. If you told him you have bleeding from your back passage, he will tell you no, but he has black stool. Okay, so you should ask about black stool by name. And if female, you should ask about menorrhagia, any heavy menses. Okay, so these three questions about to check if any evidence of blood loss, and also to assess the diet, okay, to check what is the cause of anemia. So here he had black stool, okay, and he had features of acromegaly. He had abdominal pain. He had also heartburn. He had hand pain. He had polyuria, okay, over the last 1 year, and also he was diagnosed with diabetes. Okay, so you have here like, and also as I mentioned to you, you have to ask questions related to the acromegaly, as you know, all the complications of acromegaly, obstructive sleep apnea, carpal tunnel syndrome, the heart failure, hypertension, the diabetes, and also the colonic carcinoma, colonic cancer, and also the inclusion in multiple endocrine neoplasia. You will ask about the gastrinoma or insulinoma, and also the hypercalcemia symptoms, either polyuria with constipation. But this patient has loose motion because he had melena. The melena caused his loose motion. Okay, so I think that will be better. Like if you like try to organize from the start, you will reach rapidly to the diagnosis, and your questions will be more targeted, because also the examination here also is detailed examination. Firstly, you need to check the patient hand, okay, to check and also to compare his hand with your hand, and then you need to check signs of activity. You will check the sweat, excess sweat by the dorsum of your hand. Then you need to examine for carpal tunnel syndrome to do the tail test. Then you will ask for the blood pressure and also ask for the blood sugar. Then you need to examine for proximal myopathy, okay, by abduction and adduction for the shoulder, and ask him to stand from sitting position unaided. Then also you need to examine the neck for acanthosis nigricans and skin tag. Then you examine the face from the side and from the front. From the side to see prognosis, okay, and from the front to and so also prominent supraorbital ridge. And from the front, you will ask him to smile to see for interdental separation and large nose. And also you need to do full eye examination in this patient. Okay, he has also blurred vision and he has headache. You need to do full eye examination. You need to check the visual acuity and the visual field for bitemporal hemianopia. Even if he told you I don't have pumping, or I don't know if I cannot see sights, you need to examine for bitemporal hemianopia. And also you need to ask for fundoscopy for papilledema and also optic atrophy. Then you need to offer also thyroid examination because some cases may have goiter. And then you go to check for heart examination as you did, the apex and base of the lung, and also for lower limb edema. And you need to do abdominal examination for any palpable masses. And also if he has joint pain or knee pain, you need to examine the knee. Okay, so it's like, as I told you, it's detailed examination, but this is very common case in the exam. And it can come by multiple presentation, can come by headache, visual disturbance, can come by multiple weight gain, okay, can come by multiple presentations. So it's better to catch it early and direct your
But
questions.
you are sure, Dr. Ali, they sometimes hidden the patient from
Yeah.
the start?
Yes, yeah, and also maybe the patient is sleeping, giving you your back.
Hmm.
Unless you ask her to see. If you want, you can ask to see the patient. If you suspected, like
if I ask you to see the patient, there's no problem.
no problem. Yes, yeah. But if you suspected, like he has weight gain and suspected, but also some patients, even with acromegaly, you may not like find the gross features of acromegaly that we are bringing in photos. Okay, some patients may not find the gross feature. First, to be in the safe side, you ask about the facial appearance and also the change in the size of ring and show.
Okay, when I face a case like that with multiple symptoms like fatigue, weight gain, headache, pins and needles, lung vision, abdominal pain, diarrhea, polyuria, more symptoms, how I can do with analysis of this of every complaint?
I think if you are minded by the case, if you know this is like if you find it like the patient has polyuria, okay, just a few questions. Yeah, you don't like have to ask a lot of questions because you are minded. This is mostly either related to diabetes or related to hypercalcemia from the multiple endocrine neoplasia. So that's why I told you when you get such case, okay, I think also a lot of cases like this, they are like wealthy cases. When you go inside, you will find a lot of symptoms, and also you have to do a lot of examination. So when you find case like this, you are minded what you want to hear and what you want to take in detail and what you want to just like pass by it. Okay, I think this coming by the practice. The investigations, as you have mentioned, here the differential diagnosis here multiple endocrine neoplasia type 1. This is the first differential. I'm sorry, this patient also the examination. This patient has melena. This is essential to offer digital rectal examination in this patient. Okay, you need to offer the digital rectal examination. So the first differential here is multiple endocrine neoplasia type 1, or you can say acromegaly with colonic cancer. Okay, maybe the polyuria is because of diabetes, as you have mentioned. So yeah, the investigations, as you have mentioned, the basic blood test and the oral glucose tolerance test, the insulin-like growth factor, and the MRI pituitary, and the full pituitary hormonal profile also we need to do. And here also essential the upper GI endoscopy, and also when addressing the patient concern, you should inform him that he need to be admitted, and also you will arrange for him a camera test because he has upper GI bleeding. The MRI pituitary, and also the colonoscopy and the upper GI endoscopy, and the complication, the ECG and the echocardiogram, and the calcium and the BTH, and also the blood sugar and the hemoglobin A1C. And the treatment, as you have mentioned, it's mainly surgical treatment and maybe also radiotherapy. And also there is a medical treatment, somatostatin analog, as you mentioned, lanreotide and octreotide, and also the dopamine agonist like cabergoline, and also the growth hormone receptor antagonist, which is bigfizomib.
Okay, thank you, Dr.
Okay.
Okay. Yeah, thank you, Dr. Ala. Well done, Dr. Hari. If you mentioned the min as a differential, I heard you, but you said min 1, 2. You want to say min 1 only, okay? Take care about the terms. So if you mention it, you can get the good mark in the differential, because I minus you in the differential because I thought you didn't mention min, but if you mention it, so it's okay to get full mark, min and acromegaly as a differential. You got the case, but need to be, as Dr. Ala said, a little bit organized to save your time. The problem here is the time management. 2 minutes to do the concern and to do the examination. Take care, it will affect your marks in the examination and the concern. You will not cover everything. So let's go back to the clinical communication, the history taking. I prefer to ask the past medical history after constitutional symptoms, as I usually do. So, analysis of the complaint, relevant system, constitutional symptom, then the past medical history or surgical or medication. Why? Because here you have diabetes. It's one of the complication of the case, which is acromegaly, and you have to analyze the complication of diabetes. You ask only for the intimacy or intimate relationship, but you didn't ask about the other complication of diabetes, like the neuropathy. Here you have retinopathy, or you have vision problem because of bitemporal hemianopia, or you don't have it, right? He said blurring of vision or no, Dr. Ala? There is? There is, right? Blurring of vision.
Yes, there's blurred vision, and he asked all the questions, but included in the assessment and his history. He
And
asked
that's
all the questions.
CNS. Yeah,
Yeah,
he
yeah.
asked in the CNS. Exactly.
Pencil needles, vision problem, urine problem. He asked all. Then he
But
added the intimacy.
hypoglycemia, he didn't ask, right?
No.
Yeah, so the point here, or the advice, to do past medical history analysis earlier, because the systemic review will cover the past medical history, including the long-standing disease and the systemic review, which can be affected in our scenario. Okay, do it as once or two in one. Two in one. The past medical history and the complication of the long-standing disease on the systemic review. Better than asking about the systemic review, then you will discover there is diabetes. Then I want to analyze the diabetes, and it will take another time. So I will not save, and I will not have time to do the examination. This is the problem. Whenever you start to ask about the past medical history earlier, you can save the time to analyze the systemic questions related to the past or to the long-standing disease. Be regular, be systematic, be organized in this way, and ask the systemic review. Whenever you have positive, don't be panic. I think, Dr. Hani, you are panic whenever you have something positive. Oh my God, is it related or is it distractor? How to link it to the case? Okay, so be calm whenever you have something positive. Analyze it. You have good approach. You are asking about the site, the timing, the place, the radiation, the scale. You can ask all these questions, but be calm. Don't be panic. You can cover everything. You have the good knowledge to cover every point you can ask about, or the examiner will ask you about. Okay, you have good knowledge. That's just to be more confident. Don't be panic, because whenever you feel panic, you will not answer quickly and you will not answer fluently, and the answer will be like hesitant. Okay. This is the regarding the clinical, the examination. You ask, you didn't examine the face, however, you picked up there is prognatism, but the examiner will tell you, how do you know? So you have to examine, open your mouth, the tongue out. You will stand beside the patient. Of course, it was short time to do, but if you have good time, you will cover this part of examination. Carpal tunnel also need to be examined. I think you will examined. Cardiovascular, you remember to ask and to examine the cardiovascular. However, in the exam, there is no time to examine the all cardiovascular examination steps. But at least you offer to the examiner, I want to examine, or I would like to examine the heart. He will say no, because you don't have the time. The abdomen for organomegaly or for tummy pain as you have in this scenario. Digital rectal examination, I would like to do it if I can. The examiner, of course, will tell you no need or skip. Okay. Parathyroid, it's very important to rule out men by two questions. The first question related to the family history. As we know, men is one of the autosomal dominant condition, so he will have history of family or family history of same condition. And the other thing, by the history or the systemic review question. Parathyroid swelling, you ask about the lump in front of your neck. You have analysis of the diarrhea, but you didn't ask about the relation to food, which is not positive here, of course, but you have to know, is it related to food? It might be as an autoimmune association, celiac, however, it's not the condition. But whenever you have diarrhea, you have to analyze it in this way. The way you ask about, is it watery? Is it flushable? And relation to the food, any blood with it. Okay? You missed only the question relation to the food. If you have a celiac disease, you cannot catch the diagnosis. So any question of this question, if you missed, you might lose the case. Ask again about the watery. Is it watery? Is it flushable? Related to the food? And does it contain blood? Contain blood means cancer or inflammatory bowel disease. Related to food for celiac. Flushable or no for malabsorptive diarrhea. And watery or this is for gastroenteritis or for the again malabsorptive diarrhea if you have fatty or slime, it will contain slime. Okay. These four questions always ask about any diarrhea whenever you have the complaint of diarrhea or in the systemic review questions. Clue here also about the weight gain. You just ask how many and you didn't know where exactly he put the weight. By the way, Dr. Ala put the photo at the end of the discussion, not earlier. Okay? He put it at the concerned time. But to analyze the weight, let's summarize it. You have either weight loss or weight gain. The weight gain is very easy to analyze. How many over how long? Okay? And how is the appetite? Of course, the appetite will be preserved. No one will increase his weight without loss appetite or without increase the appetite or preserve. Will not say intact. We will say preserved appetite. The only patient in PACES, this is an exception. The only condition in PACES, the patient will have loss of weight and he will have increase weight. Sorry, a loss of appetite with increased weight. Who's this patient? The only patient in PACES who will have increased weight with poor appetite. Who knows this patient?
Hypothyroid.
No.
Nephrotic syndrome.
Malignancy and
Again, Dr. Bassel, what is the question?
The only patient who has loss of appetite with increased weight. He has poor appetite and his weight is increasing. Oh no, it's not Cushing. Appetite is low. Poor appetite. He has a cancer. Despite of that, he has weight gain.
Insulinoma.
Yes,
Insulinoma.
insulinoma. Perfect. Yes, the insulinoma patient, in the only patient in PACES who has increased weight with poor appetite because of cancer. Okay.
But I think in insulinoma, there is no poor appetite. The
As a
patient eating.
cancer. As a cancer, I'm talking about. Yeah.
Even as a cancer, insulinoma, it is with increased appetite actually, not poor appetite.
Okay.
You can check.
I'm talking about a cancer, nature of a cancer. Okay. Anyway, this is the only patient who will have a weight gain with poor appetite. Yes, he's eating, but I think with the poor appetite. And anyway, otherwise, you will have the patient. Let's go back to the analysis of weight gain. Patient will have weight gain. You have to ask about where exactly he put the weight, plus over how long and how much. How much over how long, and where exactly you put this weight. If is it in the hands and feet and face. So this is a case of acromegaly, as our case today. Second condition, truncal or central or interscapular. So mainly in the trunk. This is Cushing plus the face, cushingoid face. Okay, but don't say buffalo face. Don't say it ever. Don't say patient is having buffalo face. Or you can say weight gain in his face and interscapular or central in the tummy. The last patient, generalized weight gain or weight gain all over in the hypothyroidism state. Okay, what about weight loss? How to analyze? How many kilograms over how long? And what about the appetite? If the patient is having preserved appetite, so you are talking about which condition? Again, the question. Patient is having loss of weight, however, he is having good appetite.
Thyrotoxicosis,
Perfect.
diabetes,
Perfect.
malabsorption,
And pheochromocytoma.
pheochromocytoma. Yes.
Okay, pheochromocytoma, diabetes, malabsorption, thyrotoxicosis. There is mnemonic, some doctors, I'm not saying this is mine, TBDM, 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 TB, T for thyrotoxicosis, B for, sorry, T thyrotoxicosis, yeah, P for pheochromocytoma, D diabetes, M malabsorption, P for pen, not for book, TPDM. Okay, T for thyrotoxicosis, P for pheochromocytoma, D for diabetes, M for malabsorption. Okay, this is the first condition or the first category. The second category, patient will have poor appetite with weight loss, and this is a serious condition, either infection or cancer or connective tissue disease, and this is a common condition. So never ever patient will have poor appetite and he will have weight gain. Okay, so he will have poor appetite with weight loss, and he has serious condition ongoing. Why? Because of the poor appetite. Okay, I think we are done with the weight gain analysis and weight loss analysis, and what are the conditions related to both condition or both complaint. Any question or comment from Dr. Ala and Dr. Hani? Anyone checked for insulinoma and poor appetite? Okay, I just Google it. You can hear me, right? So the first, the general finding, while insulinoma typically cause excess hunger, hyperphagia due to chronic hypoglycemia, some patients can experience reduced appetite, nausea, or weight loss due to tumor-related cachexia. Okay, this is as Google. I will also refresh in the group. Yeah, atypical presentation. Although commonly linked to weight gain from overeating to combat low blood sugar, some insulinoma patients present with unexpected weight loss or poor appetites. So they might have also weight gain due to the hyperphagia, but the poor appetite also might be there. Clear? Clear for all? Okay, I will read the chat box because I missed most of them. Digital rectal examination, I mentioned earlier. Cushing, thyroid, no. Hysteria, this question was related to What question for the hysteria or hysterica? What was the question that time? Sorry. About the weight, right?
About weight gain, weight loss with weight gain with low appetite.
Okay, weight gain with low appetite. Yeah, we mentioned the insulinoma. I don't think a hysterica patient will eat. Hysterica, you mean eat without appetite? No, she has preserved appetite. The hysterica will have preserved appetite, but the patient will not wait, or will not eat, and he will lose the weight because of reduce the intake. Okay, Dr. Real Note wrote, yes, eating more. We discussed this now. We refresh it from anyone has information he can add. SLE nephropathy can increase weight with loss of appetite. Good point. So the weight here will be water retention, right? Good point and good to mention it. So the patient with SLE as connective tissue disease, he will have poor appetite. Although he will have gain weight because of the water retention. Perfect to mention. I'm sorry, Dr. Basim, I have to leave. Okay, Dr. Hani, no worry. I leave the session now, no problem. TPDM, yes, TPDM for the weight loss, although the appetite is preserved. The patient is eating, but still he cannot gain a weight because increase of the catabolism or the metabolic state. He has high catabolic state. T for thyrotoxicosis, P for chorocytoma, D for diabetes, M for malabsorptive diarrhea. So he will eat well, but he will not gain the weight. Even he might lose the weight. For weight and good appetite, yes, this is the mnemonic. Okay, weight gain or weight loss with good appetite. Okay, clear now this point. Any question for the point for first scenario or second scenario? Any question? Okay. Patient, let's repeat it. For insulinoma, patient, he might have hyperphagia, so he will eat more. Or maybe he will have, as a cancer, he will have poor appetite. Okay, but in the state of hyperphagia, he might gain a lot of weight. Later on, he might lose the appetite. However, he gained a weight already earlier because of the hyperphagia. Any question before ending the session? Okay, thank you, Dr. Hani, Dr. Ala. Thank you, everyone, for the comments.
Thank you, Dr. Basim.
Okay. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.